Welcome to a clinical deep dive on chronic conditions. For the 2025-2026 period, the Australian Dental Council transitioned its written examination entirely to a scenario-based question format. This assessment model prioritizes a candidate's ability to execute complex, multifactorial clinical reasoning, moving away from the simple recall of isolated medical facts. Practitioners must demonstrate they can safely bridge the gap between systemic chronic disease and routine dental therapeutics. We are going to deconstruct a high-risk patient scenario, one involving multiple comorbidities that complicate a standard extraction. Navigation of these scenarios is dictated by three specific Australian texts. As this Venn diagram shows, the intersection of the Therapeutic Guidelines version 4, the Australian Medicines Handbook, and the Chronic Conditions Manual defines the current Australian standard of care. Overseas trained candidates frequently struggle by relying on international norms. Passing the ADC requires synthesizing clinical data strictly from these specific local references. Our clinical subject is Manuel, a 65-year-old patient who requires the extraction of a badly broken down tooth 37. His medical history includes two major factors: atrial fibrillation and stage 3A chronic kidney disease. Manuel's current pharmacotherapy includes the ACE inhibitor perindopril and the anticoagulant apixaban. This is a standard scenario-based setup designed to test whether a practitioner understands how systemic health limits local treatment options. Let's focus on the atrial fibrillation and his apixaban prescription, a direct oral anticoagulant, or DOAC. A common and dangerous error in these assessments is instructing the patient to halt their anticoagulant therapy before the extraction. This visualizes the clinical trade-off. On one side is the severe risk of a thromboembolic event, like a stroke. On the other is localized postoperative bleeding. The 2025 guidelines strictly advise against routine DOAC interruption for low to moderate risk procedures, like simple extractions. Since you cannot alter systemic drug levels, the clinical burden shifts to the site of surgery. The ADC expects you to employ physical interventions, placing oxidized cellulose in the socket, using a tranexamic acid mouthwash, and securing the site with sutures. For a patient on a DOAC, maintaining cardiovascular stability always takes precedence over achieving a bloodless surgical field. Now we pivot to the second systemic factor on Manuel's dashboard: chronic kidney disease, stage 3A. This matrix shows the two physiological markers used in staging. eGFR measures the filtration rate, or overall function, while ACR measures protein leakage, a marker of damage. Manuel's ACE inhibitor, perindopril, is currently managing both his hypertension and his renal disease progression. This clinical profile makes the patient vulnerable to a pharmacological event known as the triple whammy. The first two components are already present in Manuel's history: an ACE inhibitor and a diuretic. The dentist introduces the final, dangerous catalyst by prescribing a standard NSAID for post-operative pain management. Combining these three drugs causes a severe, sudden drop in renal blood flow, which can trigger acute kidney injury. In this scenario, you must avoid NSAIDs entirely. You must also explicitly instruct the patient to avoid over-the-counter anti-inflammatories. When calculating dosages for alternative medications, practitioners must refer to the Australian Medicines Handbook. This chart highlights a critical distinction. While eGFR is used for diagnosing and staging CKD, you must use creatinine clearance, or CRCL, for calculating safe drug dosages. Using eGFR and CRCL interchangeably when prescribing for a renal patient can lead to the toxic accumulation of drug metabolites. Safe prescribing requires you to look beyond the oral cavity to understand the precise clearance capacity of the patient's kidneys. This logic extends to antimicrobial stewardship, a core pillar of the Therapeutic Guidelines version 4. This chart displays total community antibiotic prescriptions in Australia. Note that dentistry accounts for approximately 7 to 10% of this total. A common clinical trap in these exams is the urge to prescribe antibiotics for a localized dental infection before or after an extraction. The Australian standard is clear: operative management, the extraction itself, or the drainage of the site, is the definitive treatment. For Manuel's specific case, routine antibiotic prophylaxis is not indicated. Prophylaxis is reserved for narrow exceptions, such as patients with prosthetic heart valves or specific congenital heart defects. Overprescribing in an SBQ violates stewardship protocols and harms the patient's systemic balance, without offering any additional local healing benefit. We can collapse this scenario into a unified workflow for clinical practice and exam preparation. Step 1 is information gathering. Map the patient's renal function and medication profile. Step 2 is guideline consultation. Cross-check drug interactions using the AMH and therapeutic guidelines. Step 3 is treatment modification. Execute local hemostasis and strictly avoid nephrotoxic drugs. The ADC assessment reinforces one vital principle. A single tooth is never isolated from the patient's systemic health. In Australia, the profession is moving toward digital platforms like the Therapeutic Guidelines app for real-time, evidence-based data. Success in the ADC exam means proving you are a safe, integrated primary healthcare provider. Subscribe for more clinical deep dives to master the Australian standard.